Let's get started. Good afternoon, and thanks for participating in the Brand New Day HCC Training webinars. My name is Michelle Reed. I'm with the Brand New Day Risk Adjustment and Coding team. So today, just want to cover, we're getting close to sweep, so we want to talk about, some of the basics in terms of risk adjustment, how scores are calculated, and how members are actually given a RAP score and what are the components of developing that RAP score. And then we'll go into, some of the commonly missed chronic disease or conditions and examples of the ICD-10 codes that we would use to apply the commonly missed diagnoses. So a few best practice slides that we have here today. We'll also just touch on your data submission, making sure that all the encounter data that you're working so hard at including is captured in the data and where we could possibly look at best practices to identify potential areas of gap. Questions. If you have any questions regarding any of the slides or any of the conditions, please feel free to drop them in the chat box. If we're able to answer them today, we will. If there's questions that we're not able to answer during today's call, then Liz will record your questions and we will answer questions outside of this forum and we'll provide you with a response to your questions. Okay, so let's get started. And sweep dates. I will be sure to cover the CMS sweep dates towards the end of the presentation, but I did want to just inform you that there was an extension for the 2019 service dates. We're able to capture and collect additional supplemental data. So towards the end of the presentation, we'll talk about the submission timelines and dates of service that we're looking for in order to capture additional data and the dates that would cover those submissions. So let's jump right into it. Just a couple of basic, what's an HCC for some of our new participants. HCC or hierarchy condition code category, it's a risk adjustment model that calculates risk scores for aged and disabled Medicare beneficiaries. So these scores represent the expected medical cost of a Medicare member in the coming year. CMS uses the risk scores to calculate its per member per month fees to payers. So as those diagnoses go into the system, the diagnosis code holds a weight and a calculation is applied to those scores. HCC coding seeks to identify Medicare members who have severe or chronic health issues. So individual diagnoses are classified using the ICD-10, as you know. There are more than 9,000 ICD-10 codes that match to about 79, there's a few more now, HCC code categories contained in the risk adjustment model. So for those that are not familiar, the risk adjustment model is a table that's released by CMS. It includes all of the diagnoses codes and a risk adjustment code or an HCC code that will map to the diagnosis. So not all of your ICD-10 codes will map to an HCC code category. So based on this information, along with other factors such as patient's age, patient's gender, Medicare members are given a risk score. And this score is used to help to determine the Medicare reimbursement. Okay. So CMS uses an HCC coding and other information from the physicians to determine the risk adjustment factor scores. So a patient's diagnoses is the central for scoring. So it kind of starts the diagnoses, but there's other factors that are used to determine a member's risk score factor. For example, a patient's age will influence the score because older individuals have higher than expected medical care costs. So CMS will also consider eligibility as part of the status when factoring risk scores. CMS looks at whether a person's aged into the Medicare program or became a member because of a disability. In addition to that, CMS will look at whether a patient is enrolled in both Medicare because of age and Medicaid because of a disability. So you may hear us, I'm just going to drop back down here. You may ask, we're looking at data when we're reaching out to physicians And we tend to look at specific data as far as whether a member is moving into a health plan from fee-for-service Medicare, or whether a member is moving from one Medicare Advantage plan to another Medicare Advantage plan. That information is important to the health plan when looking at data, because we've discovered that when members are in a fee-for-service based Medicare world, we tend not to capture all the diagnoses or conditions that we would have if they were in a Medicare Advantage plan where we were looking at member risk based on diagnoses. So what we do when we work with providers, we look at those members who are in a fee-for-service based world, identify if we've captured all of their chronic diseases and conditions, and then that's the type of data that we're looking for in order to increase the members' baseline on their RAF score. So you may have, someone reaching out, ask if this was a fee-for-service Medicare, and maybe we go in and we look at the data that was previously submitted to Medicare, and then we look to see if we can build on those diagnoses for future office visits. So HCC breakdown. So here's just a quick, really high level breakdown of the risk adjustment process. So we have the patient demographic that we talked about, and then the diagnoses that then go into that table. And then ultimately we come out with a risk adjustment score or factor for the member. The demographic information for risk includes the patient's age, the patient's gender, whether the individual lives in the community or in a skilled nursing facility, whether the individual enrolled is in Medicare, Medicaid, or if they're dual eligible in both programs. So these factors and demographic data all ties into how a risk score is developed for a particular member. Diagnoses. So the diagnoses are recorded using the HCC code. So we talked about HCC diagnosis code being mapped to an HCC code. The codes are based on specific ICD-10s. Medical conditions are in a hierarchy and they're weighted. So in the HCC code model or table, all of the diagnoses codes that are mapped to an HCC, there's a hierarchy or a weight that determines the amount or the payment that's associated with a particular diagnosis. So when we're determining a risk factor in the adjustments, the RAF values are assigned to the HCC. The RAF score for HCC is higher if the patient is sicker. So the more diagnoses we have for a patient, the more sick, the more chronic disease they have in their profile, the higher the RAF score. And RAF scores are additive. So we've talked about in some of the previous trainings, diagnoses codes that could be submitted in addition to others, which would increase the RAF. And then of course, the RAF score baseline demographic is based on the calculation of less than 1. So here on this slide, the CMS risk adjustment model includes about roughly 79 HCC code categories of diagnoses for chronic diseases and illness, and it's mapped to thousands of ICD-10 diagnoses codes. And some of the codes that conditions we've listed here are some of the more common ones. So COPD, congestive heart failure, vascular cancers, diabetes. So these are some of the chronic disease and conditions where we go back and we look at prior year conditions. So we're looking back 3 years prior to see if any of these conditions, which weigh fairly high on the HCC code model, are missed in any of our patient statuses. If they are missed patient status, you are receiving information asking that you would validate conditions, diagnoses, or send in medical records. We also use several other algorithms to determine if any of the diseases are missed. So we look at medication data. So we will run medication profile on the members to determine if there are medications that the members are currently being prescribed where we do not see a diagnosis consistent with the medication. So most common would be metformin, if metformin's in the profile, but there's no condition of diabetes. Then we would look to see if we're missing diseases or conditions related to the medication. We also have lab algorithms. So there are certain tests or certain labs that we find in a patient's profile where we don't have a consistent diagnosis, asking the providers to validate if a particular condition exists. And then thirdly, we're looking at the coding and the specificity of the diagnoses codes received. So are we coding to the greatest level of specificity? Are there fourth or fifth digit ICD-10 codes that should be documented in order for us to capture and collect the conditions? So in a disease such as diabetes, there would be comorbidities associated with diabetes. And we'll look at some diabetic slides later on to make sure that we're capturing all of the diseases listed there. Okay. So it's important to remember that one of the key goals of HCC coding is to predict the use of medical services and Medicare members in the year to come. So for this reason, HCC diagnoses coding, it looks at all conditions a patient has been diagnosed over the past year, which places great importance of recording the comorbidities. So the coding assignment, the coding assigns a weight to each condition, and these weights combine all the demographic to determine the HCC score. High scores mean that the patient has more complex and serious conditions and will use more health services, resulting in a higher cost. So the more diagnoses we have that are captured in the condition, the higher the RAF score and the higher the payment in order to care and accommodate a lot of the members' healthcare cost. So to comply with the CMS regulations, provide the best and most efficient services to the patient. So we receive the reimbursement based on the documentation you provide. And so a lot of you are working really hard, submitting progress notes and making sure that the doctors are validating conditions. So it's important that we get that data so that you receive the reimbursement that you deserve and that we're able to care for the patient because we now have the funds and the resources based on the documentation that's coming in. So here are some key steps that we can work on or we've discovered in order to make sure that that information is being received. So accuracy. So when I say here CMS denies a claim, when we say deny claim, they will take in the data. However, this goes back to specificity. So if a diagnosis comes in and it's not specified to a degree that it's listed on the HCC code model, then CMS will reject that particular diagnosis because it doesn't meet or it lacks the specificity needed in order to capture on the HCC code model. So we want the specificity in your encounter data to make sure that we are capturing the data necessary to maximize on RAP. So if you have a condition such as diabetes and you have a biller that may submit unspecified diabetes, and maybe in the progress note or the chart, the doctor has documented the diabetes and maybe peripheral or some other chronic disease associated with it, making sure that we use the diagnoses codes that would support all of the comorbidities would make sure that the accuracy of your conditions are being accepted by CMS. Another best practice is understanding the patient population. So if you serve Medicare patients, it's more likely than not that a lot of them have been diagnosed with either diabetes or vascular disease, one or more of the common HCC codes diagnoses we looked on the previous slide. So understanding the patient population, making sure that we have a system in place to identify those chronic diseases and that we're running the right labs and tests to make sure that we can recapture the conditions and keeping our records up to date. So each year there is an annual wellness exam that your provider will complete on your members. So if you understand your patient population and you have stored their information in prior years, when those members are reassessed, you have the information needed to make sure that you're capturing those diagnoses that you've addressed in prior years. So capturing comorbidities, we want to make sure that we're applying all the comorbidities associated with the primary diagnoses, and it goes again back to specificity. So we want to be sure to capture every diagnosis that's in the patient history if it's still relevant. For example, we talked about diabetes, but there's hypertension and there's depression and there's also other conditions that could be captured associated with the comorbidities, and making sure that we have accurate records and we have sight of those conditions that are associated with primary. Reporting every year. So the CMS risk management model is built on reviewing a previous year's health status to predict the following year's health expense. So this means that physicians and practices must report their information to CMS every year. So we want to get in the habit of using HCC codes and diagnoses codes and submitting in a timely manner. So the earlier you can get your diagnoses codes in, of course, you're able to have those codes stored into the CMS system so that your data is captured. So if we're waiting to the end of the year, we're missing what we call CMS sweep dates. So CMS has a calendar and they say they're going to capture all the diagnoses during a January sweep. Then we'll capture additional diagnoses in the March sweep, and there's the September sweep. So the earlier you're submitting your data, the faster we're showing that CMS has collected those diagnoses codes or HCC codes that will then start to increase a member's RAF and increase payment. So when we're waiting to the end of the year or right before sweeps, we run the risk of not capturing data timely. So key here is reporting every year timely and hopefully early as possible, within at least the first 6 months of the year, getting your patients in for an annual wellness exam to ensure that data is captured and collected. So here's just the CMS model. We're focusing on long-term conditions such as diabetes, COPD, congestive heart failure, that impacts the future healthcare costs. And so these are some of this is a table that comes from the model. It just basically shows an HCC code table with samples of some of the diagnoses and conditions. I added HCC 8 here is we tend to see a lot of cancer diagnoses or leukemia diagnoses, but there's documentation to identify when those conditions are metastasized, and that will drive your HCC payment. So a cancer diagnosis with metastasized attached versus metastasized will not show in the model if you're not documenting it. So it's key to make sure we're being very specific when documenting conditions and HCC codes. So these relative factors contribute to the patient's RAF score. So an individual may have 0 or 1 or multiple HCCs that impact the RAF score that's calculated every year. So on January 1st, the patient's HCC listing, it's blank. For example, a patient with diabetes and complications would need to have a face-to-face encounter with a provider where diabetes is discussed and documented for the appropriate HCC to be reported in the new year. So it doesn't mean that the HCC model says that they're cured, but rather that the requirement encourages, traditional Medicare fee-for-service type arrangements and contracts to reassess those conditions for continuity of care, for disease management and case management. So every year the slate is wiped clean. You must re-document or face-to-face visit with providers and resubmit the chronic diseases associated with those patients' history. So focus here is yearly code capturing and education. So provider education, making sure that our doctors are aware of what those new codes are or diagnosis codes are that will be added to the models. We know that dementia was added to the model. CKD stage 3 was added to the model. So being vigilant of which codes are new to the model, which codes we can now report, making sure that we take a look back at those conditions that were now added to the model in order to capture new HCC codes for upcoming sweeps. So another best practice, and this is something we see frequent in our data, the data submission. So payers and providers, we want to ensure that all ICD-10 codes for the encounters are captured in your electronic health record and that the data is passed over through your practice management systems. So a lot of you may be familiar with the term 837. It's an electronic data format that allows us to take in your ICD-10 codes from your practice management systems. And what we find is a lot of practice management systems can only pass through 4 diagnoses or 6 diagnoses, and it doesn't accommodate all 12 diagnoses allowed on a professional claim or all 25 diagnoses allowed on an institutional claim. So this means that we have a potential gap in data. So the billing staff, if you have to prioritize diagnoses, we want your chronic disease or diagnoses listed first, or submit a subsequent encounter to ensure that we're capturing the remaining diagnoses. So if a patient comes in the office and they have, a cough, which is their chief complaint, but doctor also addresses some sort of condition related to their diabetes, if all of your non-HCC codes are coming in diagnoses 1 through 4 and your practice management system doesn't allow us to capture all 12, you're going to leave diagnoses and dollars on the table because we're not collecting all of your diagnoses. So taking a look at your practice management system and ensuring that we're receiving all 12 diagnoses or more when you're submitting encounters would definitely help to increase risk. And a lot of you may need to work with your electronic health record vendor to see if there's capabilities in order to expand your diagnoses code list. Okay. So let's talk about some useful coding tips. So these are some of the conditions that we've identified through this past month or two in terms of looking at some of the conditions and diagnoses. So every diagnosis reporting has an active condition. It must be documented and assessed and with a care plan. So you have to have a plan of care documented. The documentation should be met by either completing an annual wellness exam or through a regular progress note. So we'll take your progress note or we'll take your annual health visit in order to ensure that we're capturing all of your data. So if a patient has a diagnosis of atrial fibrillation, we want to consider adding a secondary code for hypercoagulable state, and it's D68.69. So this is a condition that we've, and for those that don't know, and there may be clinical here, related to blood clots that we tend to see missing. If it exists, this is an option for providers to take a look at charts to see if this is a condition that could be added to your conditions for members with AFib, as it is an HCC code. But it is a frequently missed diagnosis, so we want to maybe take a look back at our charts and documentation to see if this is a condition that we can add to the charts. You may also want to consider adding the diagnoses for a primary hypercoagulable state. This is unspecified, but it does risk adjust. So if a member has had a recurrent VTE or requires long-term anticoagulation for this condition, there is an unspecified code that will risk adjust as long as your charts support the data. And then here, remembering to code long-term ASA, so there's Z69.82, and or anticoagulants, there's Z79.01. So this is just the coding tips for those that are documenting AFib to take a look at charts to see if any of those conditions or diagnoses in HCCs would support additional data collection in terms of RAF. And then just a reminder, we always want to check radiology reports for aortic atherosclerosis and consider documenting I70.0 if present, and the same would be true for renal artery atherosclerosis, I70.1. So these are a couple of the commonly missed HCCs or diagnoses that we've seen in the chart where we have had radiology reports that have come in through diagnoses. So here is our kind of jumbled together diabetes charts. We talk about diabetes a lot. So for the diabetics, if the A1C is above goal, we want to consider diagnoses and coding type 2 diabetes with hyperglycemia. So here's examples of ICD-10 codes for hyperglycemia and diabetes type 2. Also remembering to code long-term or current use of insulin if it is applicable in the patient's chart. So if a member has had type 2 diabetes with hyperlipidemia, consider possible causal relationships. So there are diagnosis codes that when billed together or submitted together, there's the causal relationship. And in some cases, there is an additive value on the RAF score. So here are examples of additional diagnosis codes that could be submitted with the primary diabetes type 2. And remember to have your supporting documentation in the charts. As a reminder, we don't want to forget to monitor our urine microalbumin levels in the diabetic members. And as most of you know, we are looking for not only the hemoglobin A1C test to be generated with your diabetics, but also running the microalbumin for your diabetics, since it is one of the measures that we evaluate in your STARS. So this is also important, evaluate microalbumin. And then, of course, your diagnoses for type 2 diabetes and diabetic neuropathy code to support. Be sure to link all of the manifestations related to diabetes. So additional diagnoses to include could be CKD, retinopathy, cataract, glaucoma, and nephropathy. So all of these conditions listed here are the manifestations that may support your type 2, your diabetes. So if you're not submitting these additional codes, in addition to your type 2 diabetes, we're not capturing the manifestations. And this is really important when we're looking at the RAF scores and how we classify the HCC codes for those conditions. So more useful codes and tips. We want to screen members for PVD. So PVD, it's clinical diagnoses. Upon the exam, so if a member is noted to have signs and symptoms of PVD, so thinning, shiny skin, edema, hair loss, lower extremities, then we should be considering a diagnosis of I-73.9 for PVD. Also looking at podiatry notes. So we are looking now to determine through our data, does the PCP receive the specialty reports back to the charts in order to complete necessary follow-ups and making sure that we're coordinating with specialists. So in this particular case, utilizing podiatry notes to back up and support the information. So they tend to document the quality of and edema, the skin, the texture in their notes. So this is valuable information from podiatry, and it just doesn't stand here with podiatry. With other specialists, there's other valuable information that may not be getting back to PCP charts to help you support when you're evaluating a patient for the upcoming or the new year in order to reassess the condition. So specialty charts is key in terms of making sure that we're fully documenting the state of the condition. And so here, I honestly, I just felt like putting these here, but remember, there is a code for everything. And here you can see that, you know, there's a code from being struck by turkeys to not getting along with relationships and flag football. So there are thousands of diagnosis codes, and I know we tend to get overwhelmed with which codes are in the model, which codes are not in the model. So just to, you know, we want to take our time. There is literally a code for everything. And so we want to take our time in documentation, making sure that we're applying the correct code with the correct condition and applying specificity to those conditions in order to maximize RAF. So here are more useful tips. So bacteria pneumonia, J15.9, is not an HCC, and we tend to see that code a lot of time. And so since it's not, since it's often difficult to obtain sputum culture and long-term care, and so we may want to consider coding lobar pneumonia under J18.1 if it's applicable and it's supported by the documentation. So just understanding the difference between the J15.9 and J18.1 in order to assess and collect the appropriate HCC value for your diagnoses. Here's just a definition to kind of support that statement if you need to have further detail. So more useful coding tips related to drug and alcohol. So although we see a lot of you know, mentally ill diagnoses, we have those members that are in one of our SNPs where we tend to leave off the drug and alcohol dependence diagnoses. So these are examples of opiate diagnosis codes, uncomplicated, and benzo-dependent uncomplicated diagnosis codes that we find through chart review, but we do not find through encounter. So this slide is just kind of an explanation of what we're not finding and the appropriate ways to measure this diagnosis and include it in your submission for encounter data. So social history, when we're working on completing our annual HRA, if the member has indicated a history of ETOH or drug use, we want to be sure that we include that coding in the documentation. So for example, if it's ETOH dependence and remission, here's a code that's used for remission that we could add to our documentation in order to pick up RAF scores. So just being vigilant of these diagnosis codes, when to use them, and make sure that they're coming across through diagnoses, through your encounter data. Hypertension. So for hypertension I-10, it does not risk adjust without considering whether the member has additional diagnoses of CKD or ASHD, atherosclerotic heart disease or CHF. So these additional diagnoses, if they're present, we want to consider changing our diagnosis code. So if you're giving us NI10 and that disease is supported by any of these additional conditions, then we should change the diagnosis code. So hypertensive heart disease without CKD and without heart failure, we can use codes in this particular range. So the appropriate diagnosis codes in order to make sure that we're getting the RAF score which supports it. You must code a stage for CKD. So the type of heart failure,
Okay, ma'am.
with or without angina as separate codes.
Next will be the
Tomorrow you will not be coming through.
All right. So remember, the findings must be present for at least 3 months before we can have a diagnosis of CKD listed in the charts. So functional quadriplegia. So the definition of functional quadriplegia is the lack of ability to use one's limbs or to ambulate due to extreme debility, not associated with a spinal cord injury. The inability to move due to another medical condition, such as multiple sclerosis, Parkinson's disease, ALS, or advanced dementia. Consider this diagnosis if a member requires care with all ADLs, so including feeding, if they're bedridden, or if they have severe contractures of the extremities. So some of these associated treatments include pressure relief mattresses, feeding tubes, or chronic indwelling Foley catheters. So for our members that are, or doctors that maybe go into skilled nursing facilities, or they have some sort of homebound type practices, and members meet the criteria for functional quadriplegia, here is a diagnosis code to that will risk adjust the R53.2 if your members are supported by these particular conditions listed here. Okay. Amputations and ostomy status codes. I just like to keep this in here because we always find members that have either amputations in prior years. So the acronyms here, AKA above the knee, BKA below the knee amputation. So just remembering that we want to document the amputee once a year. We want to also make sure if there's any status codes, if they're trach or gastro, colostomy, any of the status codes, these codes will risk adjust. So I know we get in our head as billers and coders that Z codes are not on the model, but there are Z codes for certain conditions that do appear on the model, and they will risk adjust. So just understanding that we should have status codes included in documentation where it is supported and it's applicable to the patient's condition. And sweep dates. So these are our CMS sweep dates. We are looking for dates of service from January 1, 2019 through 12/31/2019. CMS has opened the window to allow us to resubmit August 2nd. So data should be submitted no later than the 15th of July. The purpose of getting your data in early is to make sure that we can accept your data through CMS and that there are no rejects. So this will generally be supplemental data. So if you had, if you're an IPA or medical group and you've had data submitted late to you from providers, we are accepting supplemental data in the form of either posting to an SFTP site, or you can submit using your 837 or EDI transactions. We will also be delivering additional health assessment tools where we've identified gaps. So that information should be, if it hasn't already, will be sent out to you as far as making sure that you have the information. And then we are also prepping for the CMS sweep in September. So these are our 2020 dates of service. So what will go in here, we'll be looking at dates of service from July 1st, 2020 to June 2020. Let's see here. And then of course, here's our deadline for supplemental. Although we don't encourage to have data submitted after, we can't guarantee that your data is going to be accepted into the CMS file. So the earlier you can get this in, the best. And I think right now should be the time that you start to look at your 2019 data. The year is closed. And so if we can get as much data in now, that would definitely help to make sure that we're accepting your submissions. Okay. And with that, I think, Liz, I think you said we had a couple questions in the chat box. So someone asked, where can they find all of the current HCC codes? CMS has, there's on the cms.hhs.gov is the website, and Liz will make sure we drop the link in the chat box. There is a model table, and the model table gives us a list of all of the ICD-10 codes. It maps them to the version of the HCC code categories that CMS has. So there are 2 versions in the model, and that outline will identify, sorry, the link is cms.hhs.gov. And Liz will provide not only a copy of the table, we'll download the table and distribute the table. We'll also provide the link to where you can find all of the diagnoses and HCC codes.
Did you mention that there was an app as well?
There is an app. There's an Optum app. It's not a brand new day app. It's a telephone Optum Care app. So if you are using an iPhone, you can look for Optum Care. And what the app does is it's an ICD-10 and also an HCC version 24 map. You could either search by a diagnosis code description, or you can put in and enter a particular code, and it will identify and tell you if the code is on the risk adjustment model or not. There's a few other, kind of valuable tips and tools in the app. So we'll also distribute the information regarding the app that you can download to your iPhone. And it's pretty handy for physicians who are kind of moving around and they want some quick information related to which diagnosis code will risk adjust.
Perfect. Can I ask one more question?
Sure.
For the hypertension with CHF code, if the provider coded CHF independently, is the hypertension with CHF code in a different category? So it's an additional HCC weighting?
So it's not an additional. So the hypertension, as you know, when ICD-10 expanded the codes to include a more specified description of the code. And I may have to get back to you on some of it because I'm not looking at all the codes and all the models, but I can tell you that the ICD-10s were expanded to include additional specificity and documentation on the code. If you'd like, for that particular question, I would like to take that back and make sure I completely understand the question, and I can give you the diagnosis codes category related to hypertension and documentation of CKD.
Okay, great. Thank you.
Sure. And since we're, and related to CKD, if you don't know that CMS did include CKD stage 3 in 2020. So before we were capturing CKD stages 4 and 5 on the risk adjustment model, stage 3 was added 2020. So we're now starting to see that as a gap in our HCC code reviews for patients and conditions. We're starting to see that those diagnoses where patients were diagnosed with stage 3 showing up as missing gaps. So providers will receive lists to evaluate those conditions and making sure that that information is included in the data. Okay.
Michelle, we have another question. What is the 837 or EDI to submit additional information? Where do we find that?
So EDI, so 837, it's electronic submission. So you're probably using a practice management system such as eClinical or Practice Fusion or maybe Office Ally. That data comes across through a clearinghouse. So for your practice management system, you may have if you don't, you can reach out to us and we'll help you identify that. But it's an electronic transaction that moves data from your practice management system through a clearinghouse to ensure that the plan is receiving your diagnosis code data. Liz, if you want to take that caller's information, we'd be glad to look at the type of practice management system you're using and validate that we're receiving your data through one of our clearinghouses.
But what is the 837?
What is the 837? I'm sorry, I'm not even, what do you mean, what is the 837? It's a transaction layout. So Liz, do you want to take that caller's information and then we can get the specific questions related to that? So it's a professional transaction layout, but we can explain more offline to the specifics of what that format looks like and talk about companion guides to make sure that you have the right information to submit across the right layouts.
Okay. Michelle, you have another one. If we have Android, looks like the Optum app is called Clinical Documentation Guide, and we can choose to filter by HCC V22 or HCC V24.
Okay, thank you. Yeah, I'm not on Android, so I appreciate that comment. Let's add that, Liz, for any users that we have that are not using iPhones, that are Android users. That would be very helpful. We can add that. Thank you for providing that information.
And a quick question on opioid use. So that's an HCC, but is there a minimum amount of use, or is it just use within 3 months or use for 3 months?
Yeah, let me take that one back to one of our medical directors so that for the clinical questions, our medical directors are agreeing with coding guidelines clinically. So if we can drop that, Liz,
Hey,
if you
Michelle.
Yes, is that Dr. Fields?
That's George Fields. You have to use it at least daily, at least for 3 months, and then you can quote it. Same thing goes for hypnotics, sedatives, anxiolytics.
Perfect. Thank you.
And remember that some PRN medication is used daily, and that would qualify as well, but it has to be used daily for 3 months. That's the criteria. And also remember, just because you're using it daily, it's, almost always doctor prescribed. It doesn't mean abuse. It just means dependency. And remember, tramadol counts as an opiate.
Thanks, Dr. Fields. And Dr. Fields is one of the medical directors with Brand New Day. So I'm glad he's able to participate in the call to provide some of the clinical feedback. So thank you, Dr. Fields.
I have a question. How about the methadone clinics? Do you characterize this also as opioid dependence?
Absolutely, yes.
Thank you.
And capture the serious mental illness that oftentimes goes along with that, from major depressive disorder recurrent to, bipolar, schizoaffective, schizophrenia.
Thank you. And if you need the ICD-10s to support the diseases or codes that Dr. Fields is referring to, we can provide you with the ICD-10 codes that would map to HCC to support.
Michelle, one question. Do you have a crosswalk for the V24 for this current year, 2021?
We do. We have the 22 crosswalk and the 24 crosswalk, so we can send that out.
Is there any fee or is it free?
It's free. Yeah, it's
okay.
Free.
So we can have it in our email, be downloading it.
Yeah, I believe, so if you've registered for this call or we've distributed this invitation, we have your email on file. If you want to just drop your specific name in the box, Liz will take it and we'll email it to you, but we're able to either post or we can provide you with a link to where you could actually find the model for the versions.
Okay, thank you so much. Appreciate it.
No problem. Okay, so we'll stay online. Liz will record the questions from the chat box. We'll get answers to your questions. We'll email the specific coding questions out to individuals. And I believe, Liz, we were putting together a frequently asked questions list so that everyone has access to questions and answers, because I'm sure a lot of us share the same questions. And we'll get those responses out for everyone. Okay, so we appreciate the participation. It's always good when we can get together and have these discussions. So we appreciate the participation. We'll stay on the line to take additional names, additional questions, and then we'll reply via email with response. Thank you for participating.
Michelle, can you hear me?
Yes.
Okay, I do have a question, and I don't know if you will be able to help me. So my understanding is, so each ICD-10 code is mapped to, or 90, as you said, 9,000 ICD-10 codes are mapped to 79 HCC score, and each HCC score has a weight that is what we take for the RAF score. Now, I understand that there are some HCC that trumps other HCC. So can you explain a little bit? Am I making any sense? I'm fairly new on this, but I'm trying to understand, when I get the RAF score for my patients, and so the way I can explain that to my executive team. Do I make sense?
It makes sense. And just high level, there are diseases that have diabetes, for example. Diabetes has 3 HCC codes, 17, 18, 19, for acute and chronic to determine the scores. So each ICD-10 is mapped to an HCC code category, and there are conditions that will trump others. So diabetes is a good one, to where acute would trump the chronic diseases, and it would pay a lower RAF score, and it would be in a different HCC code category. So we have a chart that will identify which diagnoses trump other HCC code categories. So there is a CMS document that gives us a list of all of the HCC code categories, and then there's a table to where we're using to identify which diseases hold the most weight and which diseases will trump other conditions. So I don't know, did we record the name of the caller, Liz? And we can
This is Sonia Tucker from San Isidro.
Yeah, so we can definitely provide you with the table so that you know which HCC trump others. And also with the HCC code model that we were just discussing, I think that's a very useful chart in terms of identifying which diagnoses map to an HCC code under which model. So we'll send out some tools. You can take a look at the tools so that you can pass it on to your additional staff. And if you need to have separate sessions where you want to meet with someone on our team to just kind of go through some of the mapping, we're able to do that as well.
Oh, wonderful. Thank you so much.
Good. Okay. Okay. So again, this webinar takes place once a month, the third Thursday of each month. We're willing to have recommendations regarding selected topics. So if there's a particular disease or condition you'd like to have discussed, you can send that in to our provider services mailbox, and we'll be glad to focus on some specific categories or questions that you have. So with that, we will adjourn for the afternoon. Liz will stay on for a couple minutes just to record your questions. And then if we were not able to answer questions today, we'll be sure to get back to you at a later date. Okay, thank you.